Okay, so we're going to talk about polycystic ovarian syndrome today. Is it an autoimmune problem? And I'm going to quickly go over some of the things that we have on our plate to talk to you about so that you can maybe get a feel for whether this is something that we're going to talk about, something you want to hear here over the next few minutes. A quick review, a quick overview of what we're going to do. We're going to talk in terms of polycystic ovarian syndrome, of course, what it is. And we're going to talk in terms of its prevalence, how frequently does it occur in the population, and it being multifactorial. And that's really very, very important. We're going to talk about the percentage of females who get it. And we're going to talk about how it's diagnosed, which seems to be confusing out there. Underlying causes, there are several underlying causes, which leads us to the fact that we're going to talk about its association with hypothyroidism. And we're going to talk about the relativity of obesity. Those of you who have gotten fatty liver in conjunction with this, we're going to talk about insulin resistance, which is a big key to polycystic ovarian syndrome. And we're going to talk about its role in infertility, which is quite substantial. In the past, there were associations with Hashimoto's thyroiditis. And how has that opinion shifted? Yeah, you'll have to fill me on that. Oh, we talked about that. We're sitting here, so I always thought it was understood that Hashimoto's was significantly involved. Hashimoto's is significantly involved. Hang around for that one. And what the polycystic ovarian syndrome patient can do to further investigate this, and more importantly, get it resolved, because it is a resolvable issue. So that's what we're going to talk about. So polycystic ovarian syndrome, we see it all the time. We're getting more and more people who come in with it. We've actually had a handful of people who came in because they couldn't have children and they'd already been checked, and they'd had their significant others checked, and that wasn't, and they tried in vitro and so on and so forth. We haven't had a lot of those patients, but we've had
a fair number.
Yeah,
we've been successful with.
Yeah, the ones that have come in, we have been successful. I mean, we've treated probably 2,000 fibro patients. We've had maybe 20 or 30 of those patients, or
of the PCOS patients
that we're trying to.
Oh, relative to the infertility, yes.
Yeah, PCOS patients. We've had a ton of them. Yeah, we've had a ton of those, and that's the whole point. We usually that patient will come in because they can't lose weight, or they'll come in because they don't usually come in because they can't get pregnant. Maybe they have fibromyalgia. Maybe they've developed chronic fatigue. All of these things tend to kind of interlock in different people. Different things will occur based on the fact that there's overlapping causes for all of these. So let's talk specifically about polycystic ovarian syndrome. Polycystic ovarian syndrome, I'm looking at the percentages here that you have, I guess, based on the fact that we do see a lot of these polycystic ovarian syndrome. They seem like they're everywhere in our practice. But let's talk about the prevalence in society, and how frequently it occurs. And I know a lot of patients come in and go, well, it seems like everybody has this, or it seems like nobody has this, depending on what kind of a condition they have. Let's talk about PCOS. Let's talk about the fact of how prevalent it is, and let's talk about the fact that we just kind of alluded to, that it's not just one problem creating it.
Absolutely. So yes, it is a very, very prevalent problem. Anytime you're quoting statistics, just know it varies from research study to research study. The low ball number is 5% of the female population having PCOS. The high number is 20%. I actually like the 20% number for reasons specific to it. Came from a European Obstetric and Gynecological Society study where they were looking at the numbers there. Across the board, their obesity rates are not as high as ours here in the United States are, when obesity can be highly associated with polycystic ovarian syndrome. But also know that the worldwide prevalence of this disorder, whether you're saying 5% or 20%, is growing. That's what everybody is agreeing upon. And likely there are societal factors involved, because there's such a strong relationship between PCOS and obesity and blood sugar dysregulation. So that's kind of the layout of the prevalence. It's a common problem. That's what you just need to know. Pick a safe number, 12.5%, 10%, somewhere in there. That's where
it's common enough that it's possibly responsible for 50% of women either not being able to get pregnant or not carry to term.
Exactly. It is the most common cause of infertility in the United States. Yeah. and then overlaps with Hashimoto's, which we're going to talk about today, which is also another common cause of infertility independent of PCOS. So that's the layout there. The criteria for diagnosis, everybody gets focused on these cysts on the ovaries for obvious reasons. That is one criteria for diagnosing PCOS. You have to have 2 out of the following 3. One is cysts on the ovaries. Another is hyperandrogenism, which is too much testosterone. The last one being altered menstrual cycle length. So either you're having menses every 15 days, or you're having menses every 2 to 3 months, or it's some combination of both of those. If you have 2 out of those 3 criteria, your doctor can diagnose you with PCOS. I've also talked to OBGYNs who are fairly reluctant to diagnose patients with PCOS, which I find to be a travesty. And we've mentioned this in other videos where they'll say, unless you're 300 pounds and you have a beard, you probably don't have PCOS. And that's really just not the truth. And we've seen females who are very normal in appearance. We've seen females who, yes, have problems with body mass and it being too high. And we've seen patients who have frank hirsutism, which is where you get a beard. And we've seen other patients who don't have that, who just have abnormal menstrual cycle lengths and they have cysts on their ovaries. So it's a spectrum, and many different body phenotypes, as we term them, fall into this category of PCOS. But the ramifications of this disorder are really all the same for all those different people.
And it's a problem with criteria today. We were just talking about fibromyalgia a few minutes ago, and how there's different types of criteria to evaluate it. You can have PCOS for years and years and years and years before you get a cyst, but you're still having all the chemistry and the chemical abnormalities that go along with it. And so it's really important that you understand that, because you go there and they say, well, you don't have a cyst, it's really important, if you have the other symptoms, to pursue that. So there's a number of conditions that we treat that are like that, whether it's peripheral neuropathy and insulin resistance. We're going to talk about insulin resistance, and there's a lot of in peripheral neuropathy. If you don't have frank diabetes, they're not going to evaluate you and say that you have peripheral neuropathy if you have insulin resistance. And so you're going for years and years and years where insulin resistance can cause small fiber neuropathy, and the doctor doesn't want to say it because of criteria. And now you're suffering with it. And now 15 years later, maybe you start to get diabetes type 2, and now they're willing to treat your peripheral neuropathy, and they can't do it.
And meanwhile, they changed their criteria recently to now acknowledge that.
So, and they changed the criteria again.
You could have been treated 15 years ago, but you weren't, and now you are. It's just a whole mess.
So not to overstate that matter, but I don't think you can overstate that matter. Everybody's trying to catalog everything today for insurance diagnoses or payment or whatever it is, and the patient really gets left in the cold. And this is one of those diagnoses where, if you're looking on the internet, like so many of our patients, and you have 2 of those 3 symptoms, you might want to look into it.
Absolutely.
So getting to the underlying diagnosis is all over the place.
Exactly. And getting to the underlying causes of the condition, they can be different for different individuals with polycystic ovarian syndrome. So insulin resistance is the one that is most commonly discussed. Just a simple discussion on insulin is that when you eat carbohydrates, in fact, even when you eat proteins, our pancreas secretes insulin to help get the carbohydrates from your meal, from your stomach and your small intestines, once it absorbs in the small intestines, to get that sugar into the cells of your body. That's what insulin does. When people become insulin resistant, they have to produce more insulin than they used to in order to get that amount of carbohydrate into their cells of their body. The problem with that is that insulin resistance can be highly inflammatory, and it can cause a number of downstream things to happen. One of those that is thought with PCOS is that it can cause the ovaries to start making more testosterone than they used to. So the ratio of estrogen to testosterone becomes abnormal. And then also typically progesterone levels become abnormal once this starts to ensue with the process of PCOS and the insulin resistance. So the mainstream medical treatment for a PCOS patient, first-line treatment, is to put them on a blood sugar diabetes medication called metformin most commonly, to help them regulate their insulin levels better. Now, and we'll get to natural ways to approach that, but we're not going to hit that now. So then there are other PCOS patients who we find who don't have significant insulin resistance, but rather they are making too much testosterone from their adrenal glands. So they have a genetic abnormality in their adrenal glands, which are the stress glands that sit on top of the kidneys. Yes, they make things like adrenaline, cortisol, DHEA, which is what we're talking about, which is a testosterone derivative. They do make progesterone, and then they also make hormones like aldosterone that keep sodium in our circulation to prevent us from bleeding out if we cut our arm, so to speak. But we're seeing in some of these PCOS patients, in our experience, these tend to be the thin PCOS patients. They have a tendency to make too much DHEA, makes too much testosterone. That can be part of the PCOS phenomenology. And then as a result, PCOS ensues, and we get too much testosterone. And frequently, these are patients who, when they're under stress, lots of times they'll notice their hair falls out more. So they can have female pattern hair loss, or they notice that their chest hair or their facial hair growth is more when they're under stress, because there's a stress link to their problem. So that's kind of how PCOS is approached in the mainstream medical communities. For those of you looking to get pregnant, you may know they may put you on clomiphene. You may be referred for in vitro fertilization, as Dr. Rutherford mentioned. They may put you on birth control. That is obviously not obviously, but that is a common first-line therapy for PCOS patients to help them regulate their menstrual cycles. Reason being is that it's just going to help to balance all of your hormone levels. If your testosterone is too high, well, let's give you more progesterone as an example to help you out there. Drugs like Femara are common interventions. So that's the layout of the underlying causes. But in the literature, there have been many associations with thyroid disorders and PCOS patients, because doctors were starting to see these associations where, gosh, I have all these PCOS patients and they seem to have these borderline thyroid problems, or I have these PCOS patients and they seem to have signs that their immune system is attacking their thyroid, which prompted further clinical research into the matter. And the early investigations about this showed that these doctors were seeing there were these overlapping features between polycystic ovarian syndrome and hypothyroidism. Namely, thyroid patients and PCOS patients lots of times have problems with weight. They both tend to be insulin resistant, and they both tend to get things like fatty liver, and they all have problems, not all, but they have a tendency for problems with infertility, which raises a question, do we really have, are these two conditions actually kind of one and the same, so to speak? Did you want to interject anything before I continue on?
No.
Okay,
No,
fantastic.
actually, no.
So with these research studies, they started looking at these associations, and what they found was that there's this entity called subclinical hypothyroidism. So you can go back, you can go to powerhealthtalk.com, search thyroid, you can probably even search subclinical hypothyroidism, and we did a video on that to really explain what we're talking about here. But the Cliff Notes version is such that most doctors are trained to treat you for a thyroid problem when it's really severe. And the new research is showing that you borderline, or you cases where you're just kind of a little bit abnormal or a little bit low, you actually have something called subclinical hypothyroidism, and it does necessitate treatment frequently for someone to feel optimal, for them to reduce their risk of cardiovascular disease, and for them to have a good chance of becoming pregnant if they're a female looking to do so. Now, they started seeing that a lot of PCOS patients had subclinical hypothyroidism. And then more research came about showing that upwards of 43% of PCOS patients had signs that their immune system was killing their thyroid, which was highly interesting. And that finding was kind of rebuked in the literature, and other authors said, there is no association between Hashimoto's and PCOS. And the reason why we're doing this broadcast today is that we had a question from a naturopathic student in England where she was asking us, what do you think? Is there an association there? And so I went to the literature, I sent her some articles, and there is the association. So we really appreciate her question, because that's really the impetus for this broadcast.
And I would say clinically, now we have a very select group of patients. They're all very sick. They all have chronic autoimmune problems. I would say in our office, it's even higher than
exactly. It's the
like
majority.
way higher than that. It's almost like,
right.
I don't want to be too exaggerating and say it's like 1-to-1, but it's pretty up there.
It is.
As far as the association goes.
It is. And that's what the new research is showing, that basically those of you who have PCOS have a 5 times increased probability of having antibodies to your thyroid as compared to normal individuals. And study after study is now starting to associate PCOS with Hashimoto's thyroiditis. And one thing that Dr. Rutherford said there, he said almost every patient that comes into this clinic with PCOS seems to have Hashimoto's. And that's based on the new criteria for diagnosing Hashimoto's. So around the world, there are different criteria for diagnosing this problem. So for one country, it may be the cutoff for the immune count to the thyroid may be 70. Whereas in this country, it went from 100 to 60 to 50 to 34. And now the new research is saying anything over 9 is too high for an immune count to the thyroid. That
Yeah,
comes
you
from the
might wanna
Mayo
explain that a
Clinic.
little bit.
Yeah.
Yeah, and what Dr. Gates is referring to, so there's a lab range of normal, okay? And so there's a marker called thyroid peroxidase enzyme. There's a couple of them, but this is the one most people use. And so for years, they've said it's a 0 to 65 range is normal. So over 65, and there are people who are still using this, okay? 0 to over to 65, they would say, you don't have Hashimoto's until you're over 65. So if you had it at 50 or 40 or 30 or 20 or 22 or anything like that, they would say you don't have it.
Right.
As Dr. Gates just got done saying, even in this town right here in Reno, Nevada, here at the foot of the Sierras in Western Nevada here, even here we have, in the hospital here now,
Yeah.
the hospital's like 9.
So one hospital says 9, the other one says 8.9.
Okay, for years we've been saying 9 or 10. Okay, but still, even in this town, there are labs that say 32, 24, 16. So what Dr. Gates is saying is that the review of or the fact that the lab ranges, more and more people are narrowing, more and more people are starting to be acknowledged to have it, but still we're not there yet. So there's still tons of people out there who are still being judged on that 0 to 32 or 0 to 60 and think they don't have it. And why did I go into that? Not because I'm trying to be a pain, but because I do all the intakes here and people come in and they go, no, I don't have it. See, it says I'm normal. And then I'll look at it and I'll go, well, this says 0 to 32 and you're 30. And if you were going over to Renown Hospital here, which is the biggest hospital in all of Nevada, it takes up half of Reno, they would say you have it. So that's the confusion.
Exactly. And that's perfectly illustrated. So that's the problem. So it's really a much more prevalent problem than we want.
So PCOS is really prevalent.
Exactly.
So, along with
Hashimoto's thyroiditis.
Like
and
really prevalent.
What we're seeing with both conditions is that they can affect a hormone called anti-Mullerian hormone from the ovaries. Both of these conditions seem to throw this off. So the ovaries are highly involved with Hashimoto's, with PCOS. So where's the link? What they're thinking the link is that there's poor immune regulatory function between both of these conditions. And probably it ties back to the gastrointestinal tract. So what we know with a lot of PCOS patients is that they have insulin resistance. I told you that we were going to talk about treatments. Well, the new treatment avenue for insulin resistance is the gut. And you may think, well, how are those two related? The relationship is such that we're finding that insulin resistant patients have pieces of bacteria breaking off from their gut, their intestines, their colon, going into the bloodstream at way too high of a rate. And these pieces of bacteria, as I say in every broadcast, are like dandelion flowers blowing in the breeze. And it's really hard for the liver to digest all of these bacterial components. It creates inflammation, and the liver is highly involved with coordinating insulin function. So that's one reason why. Also, there's some thought that these pieces of bacteria actually don't allow insulin to talk to your cells because they block it, if you want to think of it from that perspective. So there's a strong association between the gut and insulin resistance.
And if you're thin and you eat well and you have insulin resistance or diabetes type 2, you for sure have this.
Right. This is most likely going on. And then what we also see is that 70% of the immune system is in the gut. So there's a lot of immune regulatory function in the gastrointestinal tract, which seems to be off with Hashimoto's thyroiditis, and it seems to be off with Polycystic Ovarian syndrome. So some people are talking about fibrillin genes, other people are talking about tissue growth factor beta relative to this gut issue. Just know that it seems to tie back to the gut as to why there's this overlap and association between these two disorders. So I think that pretty well covers how in the past there were these associations with Hashimoto's. Just know now we attached 17 articles to today's broadcast. The articles at the top of the page, so to speak, as you scroll down the page, the first articles I attach are really showing you how most everybody around the world is coming to the same conclusion. I attached articles from India, I attached articles from Europe, I attached articles from Cairo, Egypt, attached articles from Iran. Everybody's really coming to the same conclusion that Hashimoto's is a major, major factor associated with polycystic ovarian syndrome. And all of the research articles pretty much conclude the same thing, where they say, yeah, these Hashimoto's patients / PCOS patients, they need to be treated for their thyroid. They need to have this stuff addressed. Now, what you may not know is that if your thyroid values are relatively normal, your doctor may not want to treat you. But go back on powerhealthtalk.com, watch our broadcast on Hashimoto's thyroiditis. We talk about how really all these thyroid problems, they're immune system problems. And you have to approach this problem completely differently, in our opinion. in our opinion. We're not anti-medication, but we're for a more preemptive strike, so to speak, for handling the immune system rather than just putting a Band-Aid on the problem and covering up the issue with a supplement or with a medication.
So what's the
unless
solution?
it's absolutely necessary. So the solution is you need to really have your gastrointestinal tract evaluated in terms of food intolerances. What we find with Hashimoto's thyroiditis is that 80% have viruses living in the thyroid. If you need a thyroid medication, then you need to be referred or see someone who can do that. And you need to have these other factors in your physiology, including vitamin D levels and stress in your gut and the virus issues, assessed. And then if you're really stressed, then you need to go back and look at your brain and say, okay, why am I so stressed? Do I have depression? Do I have anxiety?
Yeah.
Those features really need to be attended to as well. So we have broadcasts on all of that.
Yeah, and I would say my observation is the stress is the most misunderstood aspect of it. People are starting to realize now the thyroid is involved. We've been talking about the gut forever. Everybody's talking about the gut now. But in the end, what we see that is missed is people will say, oh yeah, well, you're stressed, but they don't get that you're probably a little bit more than just stressed. You're probably going through some sort of a mini to maxi to moderate post-traumatic stress syndrome, something along those lines. And this is very important because this contributes tremendously to changing your estrogen and the testosterone under certain circumstances. So when Dr. Gates says stressed, it's like if you're somebody who can't go to sleep at night, you wake up in the middle of the night, can't go back to sleep, you're getting anxiety for no reason at all, you're getting night sweats, a lot of the similar symptoms to Hashimoto's, by the way. But if you're getting that, that needs to be addressed. That needs to be addressed and it's addressed here in a different fashion than in most places, relative to not using any medications or Xanax or Prozac or anything like that. But it is and I'm just mentioning that because this is the factor when I'm doing the consults that seems to be the most difficult for people to grasp, that it's having something to do with their PCOS. In fact, a lot of patients come in here with chronic pain syndromes, and I will tell them, if you have too much testosterone and you don't have endometriosis, or you don't have polycystic ovarian syndrome, or you don't have some sort of a pathology on your adrenal glands, then you're stressed, and that's what's causing your estrogen to turn into testosterone. And that's why, unless you are certain genetic types, that's why you will develop unwanted hair here and there, and then have all these other things going along with it. So anyway, I think it's a point, whether that was correct or not, I think it's a point worth emphasizing relative to how do I get rid of my PCOS.
I agree.
And it can be gotten rid of.
It can be drastically improved.
It can be drastically improved. That would be the correct way.
Yeah.
I just got done doing something. We just got done doing something about 15 minutes ago. And if somebody tells you that they can cure you, then be a little concerned about that. We were talking about fibromyalgia.
Okay.
Yeah.
Well, we really appreciate you watching. We appreciate the comment from the individual in the UK.
Yeah,
divulge their information. And if you have any other questions, please let us know topics you want us to discuss. And you can go to powerhealthtalk.com again for further information. Search any of the things we talked about, from stress to depression to anxiety to Hashimoto's to subclinical hypothyroidism. So this is Dr. Martin Rutherford, certified functional medicine practitioner, also a chiropractor. I'm Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractor. And we really appreciate you watching.